Today we will see about antihistamine poisoning. Antihistamines are commonly recommended for the treatment of allergic symptoms. Now we will only deal about H1 antagonists. H2 antagonists such as cimetidine and ranitidine are not covered here. Antihistamines are divided into sedating and laser sedating, or previously called non-sedating antihistamines. In general, the laser sedating antihistamines have less serious toxicity in overdose than the sedating one. Let's start from the sedating antihistamines. Sedating antihistamines can have alpha-adrenergic, anticholinergic, and serotonergic effect, in addition to the H1 effect, as well as sedation overdose often present with anticholinergic symptoms. At higher doses, they can also cause sodium channel blockage with subsequent cardiovascular effect, including QT prolongation and torsade D points. There are a lot of sedating antihistamine. From this, diphenhydramine is the most commonly used one. Promethazine and others such as doxychlorpheniramine can be seen in the community. Toxicity occurs after 3 to 5 times the usual daily dose. Typical clinical presentation of first generation antihistamines is an anticholinergic toxidrome that can be remembered by the following mnemonic: dry as a bone, it dries up secretions; red as a beet, flashing; blind as a bat, mydriasis, blurred vision; and also mad as a hatter, agitation, hallucination, seizure, delirium; hot as heats, elevated temperature; and full as a flask. It is due to urinary retention and the distended bladder. Tachycardia can be quite impressive, especially if the patient is agitated. The second is non-sedating or laser sedating antihistamines. These medicines cause mostly peripheral H1 blockage with limited penetration into the CNS. In overdose symptoms, it can include dizziness, tachycardia, headache, drowsiness, or agitation. While the current generation of laser sedating antihistamines do not affect the QT interval at normal doses, there are concerns that they may have some effect in overdose. Examples include cetirizine, loratadine, desloratadine, and the like. The following children require assessment. If there is acute ingestion more than 3 times the maximum daily dose, all children or young people with intentional self-poisoning or significant accidental ingestion, any symptomatic child or young person, any child whose developmental age is inconsistent with accidental poisoning, as non-accidental poisoning should be considered. Regarding assessment, starting from history, you should have to check whether it is intentional poisoning or accidental. And also should have to check the dose, stated or likely dose taken. Calculate the maximum possible dose per kg. If possible, determine the exact name and the tablet size, present as syrup, immediate or modified release tablets, or anything. And also check for co-ingestant always. Co-ingestant can cause other symptoms or it can cause other toxicity than that of the main drug. On physical examination, we should have to do general physical examination. In addition, we should have to focus on CNS and the cardiovascular system. Check for depression or confusion or mental status. Check for pulse rate, arrhythmia, and also blood pressure. The main investigations that are needed are ECG, if it is indicated. You should have to do ECG initially and repeat 4 to 6 hours until normal. And also, if there is congested drugs such as paracetamol, you should have to check the dose. When we come to management, the first is resuscitation. Standard procedures and supportive care should be taken. For sedating antihistamines, in adolescents specifically, consider investigating for common congestant, such as alcohol, paracetamol, and the like, and monitor level of consciousness and the respiratory status, and institute supportive measures for respiratory depression or depressed consciousness level. The other thing is decontamination. Consider activated charcoal after massive ingestion in older or sedating antihistamines and within 1 hour or after airway protection. If there is seizure or severe agitation, it should be treated with benzodiazepines. Cardiac monitoring should be instituted and initial ECG performed and assessed for long QT and arrhythmia. And also consider repeat ECG at 6 hours if symptomatic. Monitor ECG for widening QRS and consider alkalinizing the serum with sodium bicarbonate if heart rate is 120 beats per minute and the QRS duration is greater than 120 milliseconds. IV fluids is given for tachycardia, urinary catheter for urinary retention, cooling measures for hyperthermia, and adolescents and adults with symptoms of anticholinergic poisoning may receive physostigmine antidote therapy. And for laser sedating antihistamines, a 12-lead ECG performed and assessed for long QT and arrhythmia. Cardiac monitoring might be necessary with large overdose and treat any effects with symptomatic management. Admission should be considered for all children or young people with intentional poisoning, and discharge criteria include if features of poisoning have not developed at 6 hours post-ingestion, normal mental status, and the normal ECG. For intentional poisoning, a risk assessment should be indicated that the child or young person is at low risk for further self-harm in the discharge setting. Thank you.